Hello and welcome to this presentation entitled Developmental Toxicity Screening of Anti-Malarial Drugs, Artemisinin. I'll be briefly describing the stages of malarial infection and its effects, the impact of malarial infection in pregnancy, the role of artemisinin, and differences in anti-malarial drug metabolism in pregnancy. And finally, I'll speak briefly about the Artemis project and our work with the World Health Organization. The most deadly form of malaria is Plasmodium falciparum, which is spread by the female Anopheles mosquito. The malarial parasite is taken into the salivary glands of the mosquito when she drinks the blood from a person suffering from malaria. The mosquito will then inject the parasite into up to 10 humans within her 3-week lifespan. As soon as the parasites are injected into the bloodstream, they travel to the liver and infect the liver cells, the hepatocytes, within minutes. And here they will differentiate into a new form, the merocytes. In the liver cells, the parasites will differentiate and multiply until they rupture. Each liver cell will release thousands of the new form of parasite into the bloodstream. These new released forms of the parasite can now invade the red blood cells. This enables the parasite to hide from the body's immune system while they multiply, feeding on the hemoglobin inside until finally the red blood cells also will burst. Infected red blood cells are normally destroyed in the spleen. However, the parasite makes these cells more sticky so that they stick to the walls of the blood vessels. This stickiness causes the major complication of the infection, cerebral malaria, which can lead to coma and subsequently death. T. falciparum is a major problem in many tropical and subtropical countries such as Africa, Central and South America, the Middle East and the Indian subcontinent, where areas of stagnant water and higher temperatures foster the survival of the Anopheles mosquito. There is widespread mosquito resistance to insecticides, and parasite resistance to anti-malarial drugs is escalating. Malaria contributes significantly to the disease burden, medical cost and labour days lost in the developing world. Malaria kills more people than any other communicable disease, at least 1 million people a year, 90% of whom live in sub-Saharan Africa. The greatest death toll is in children under 5 years old. Miscarriage, stillbirth and low birth weight are common consequences of malaria for the fetus, and it's thought that between 75 and 200,000 infant deaths could be prevented if malaria during pregnancy could be effectively controlled. Anti-malarial drug resistance, particularly in P. falciparum malaria, has been a major contributor to the global resurgence of malaria in the last 3 decades. Resistance to chloroquine and sulfadoxine pyrimethamine is widespread, while resistance of mefloquine has developed within the last 6 years in Thailand, Cambodia and Vietnam. Responses to anti-malarial drug treatment are often worse in pregnant women. It's thought that the placenta may be a site of P. falciparum sequestration and parasite multiplication. New treatment options for P. falciparum malaria have been given significant importance to stem the emergence of global drug resistance. Derivatives of a peroxide anti-malarial drug called artemisinin are recommended by the World Health Organization in combination with one or more drugs with independent mode of actions and different biochemical targets. So why artemisinins? Artemisinins are unique in that they kill the parasites inside the red blood cells. This prevents the development to a more pathological mature stage and thereby reduces the rate of disease transmission. Artemisinin derivatives are even more active than artemisinin itself. And finally, only isolated cases of resistance to artemisinin combination therapies have been reported so far. However, studies in China have demonstrated that artemisinins have teratogenic and embryotoxic potential when taken in the first trimester of pregnancy. And this has highlighted an urgent need for adequate risk assessment of antimalarials in women of childbearing age. It was Francis Kelsey in the 1950s and 1960s, now famous for averting the thalidomide tragedy in the US, who showed that conditions such as pregnancy, illness or drug interactions changed the drug's absorption and toxicity profile. Kelsey showed that antimalarial drugs taken during pregnancy reach the fetus primarily by crossing the placenta. And we now know that drug absorption, distribution, metabolism and elimination is different in pregnancy. Basically, absorption tends to be decreased and elimination increased, and thus reducing plasma concentrations of the drug. So how are risk assessments done for antimalarials in pregnancy? Well, it's difficult because pregnant women are excluded from drug trials due to ethical and medical concerns and liability issues relating to toxicity to the fetus. Because of this, most antimalarials have never had adequate preclinical embryo toxicity testing, and so the information about safety, efficacy, or even the correct dosage of antimalarials in pregnancy is inadequate. Therefore, information regarding possible embryo-fetal toxicity and the potential of artemisinin to cause structural or functional birth defects is incomplete. In the developing world, women of childbearing age may take up to 6 courses of antimalarial drugs in 1 year, and therefore unintentional artemisinin exposure during early pregnancy is likely. Normal doses may be too low in pregnancy for efficacy. However, frequent suboptimal dosing does help to foster resistance in the malarial parasite. This is a major factor in multi-drug resistance. The World Health Organization concluded in 2006 that artemisinin should not be recommended for P. falciparum malaria in the first trimester of pregnancy, except where the infection is life-threatening and where it is the only effective treatment available. Artemis is part of the 7th EU Framework Programme funding research to combat the 3 major killer diseases of poverty, HIV, TB and malaria. The Liverpool School of Tropical Medicine is coordinating the Artemis Consortium, which includes leading experts from the fields of malaria, drug development, molecular pharmacology and developmental toxicology from the universities of the Algarve, Gothenburg, Liverpool, Leiden and the school itself to investigate the safety pharmacology profile of artemisinins in pregnancy. This work will contribute directly to future World Health Organization risk-benefit assessments and recommendations for the use of artemisinins for malaria in pregnancy. For details of this work, visit the Artemis webpage at the Liverpool School of Tropical Medicine webpage or contact me directly on the email address shown here.